Hello and assalamu alaikum, dear guests. I'm your host, Dr. Akil Jaigada, and welcome to another episode of Hello Doctor, a show that works to promote good health in the South Asian community, and every week we choose a new topic. Today's topic is on cancer, sadly a condition that we all know about. Before I introduce our expert guests, it's important that you know that we have a disclaimer, which is if you're suffering from a medical condition or any other conditions that you think needs immediate care, please call 999 111 or attend your nearest A&E service. Without further ado, let's introduce our guest, Dr. Bilal Aikach.
Nice to meet you.
Thank you. Dr. Aikach, you have so many accolades and experience under your belt. I'm just going to name a few of them. So Dr. Aikach, he studied medicine at King's College London. After qualifying, he trained at Kent with a focus on medical specialities. During his initial years as a doctor, he was awarded the South Thames Award for Clinical Excellence. He then completed medical training in London and Guy's and St Thomas's Hospital, where he accomplished his membership exams at the Royal College of Physicians. After spending time as a medical registrar, he now trains as a clinical oncologist, specializing in both radiotherapy and systemic cancer treatments. In addition to this, he has undertaken projects to help break down barriers in the NHS and BAME communities. Dr. Aikach, welcome to the show.
Thank you.
It's always a pleasure for you to be here. So today's topic is on cancer, and sadly it's a condition that so many of us know about. Yeah. Either people have been personally affected by it, their loved ones being affected by it, or people who they just know have been affected by it. Just moments ago, we found out that one of the staff, unfortunately, his sister passed away from such a terrible condition. And I thought today's topic should be on cancer because for some reason, the amount of cancer rates is going up, and hopefully we can discuss this later today. Sure. But first of all, let's start with the basics. What is cancer, doctor?
So to get into this, I want to speak in a scientific term, as well as sort of what we call our day-to-day language. Reason being, in case any of our viewers are coming across cancer specialists and they hear these terminologies, they then can actually put the pieces together and understand what is actually being mentioned. So the scientific or the medical definition of cancer is the uncontrolled proliferation of abnormal cells within the body. So that sounds very complicated, but I'll give an analogy to help us understand what this actually means in our day-to-day terms. So imagine we had a phone factory, like the iPhone factory, and its day-to-day purpose was to produce mobile phones, the iPhone or the latest one, for example. This factory has mechanisms when the phone's being produced, that is producing the same phone every single time, and it's performing its functions and it has its structures. But let's say there was a problem in the production line. For example, there was an iPhone that was missing its screen. There was an iPhone that had no battery. There are safety mechanisms and checks within the factory to make sure that if a phone reaches at the end of production, it's taken back and fixed, and if it can't be fixed, then it is destroyed. And so if we imagine now the iPhone factory being like, for example, your liver, it makes its cells, it performs its function. But within cancer, the ability to check that these cells are being made properly, the ability to fix is also impaired. And what happens is these broken cells, these non-functioning cells, begin to sort of flood the market, you could say. And so they grow, they multiply, they expand, and now you have more non-functioning liver cells in comparison to functioning liver cells. And what the cancer is the uncontrolled growth of these abnormal cells, the organ's ability to lose its function as a result of this, and sometimes the spread of this mechanism in other parts of the body.
What a beautiful, simple explanation of what cancer is. I know cancer, because it's thrown around so many times, but what it actually means, the crux of it, is very hard to describe. But bringing it back to something as simple as the iPhone and explaining that it's a safety check that is being taken away from the body, and therefore that unusual iPhone or cell is proliferating, is expanding, and is taking over the body.
Yes.
Okay, that makes sense. Just going to go back to the viewers. If you have any questions regarding to cancer, the number is on the main screen. Please call the studio and ask your questions. We have an expert in the field with us today. So if you have any questions regarding cancer and the treatment and management, please do call into the show. Going back, Dr. Aikach.
Yes.
So In cancer, you hear many times benign and malignant.
Yeah.
What is the difference?
So what we do, for example, I'll talk about a patient journey at this point. And so a patient comes with what we call symptoms of cancer, and then they're investigated as such. So for example, if I had alternating bowel habits between diarrhea and constipation with some weight loss, as well as being anemic, having a low blood count on my blood test, I'll be investigated.
What does anemia mean, sorry?
Anemia means low blood count.
Okay.
Yeah, and this is can be found on blood tests organized by the GP.
Okay.
And so and then I get sent for investigations to look for a cancer.
Mm-hmm.
In the symptoms that I've been describing, we'll be looking for bowel cancer, so in the lower part of the gut.
Mm-hmm.
And so if they find it, the first question that we want to ask in terms of investigations in this process is, does this tumor or this growth of cells have the ability to spread to other parts of the body, or is it something that's focused and remains here?
Mm-hmm.
And that's the first question, because that sort of determines what we're going to do. And so benign refers to the cancer or the tumor being focused in one area only, typically in most cases being very slow growing,
Mm-hmm.
or what we call malignant or cancerous, which is what most people pass away from when they receive this diagnosis, is the ability for this cancer to grow very fast and to spread to other areas of the body.
So is a benign tumor cancer?
So in layman terms, people call it yes, but
Mhm.
in terms of, the red flags and, what sparks of all the concerns, then we say no, it's not cancerous per se, but it's just a growth of abnormal cells that is limited to that area only.
Okay, that makes sense then. So we know what benign is. It's almost a localized mistake of cells in one area.
Yes.
But malignant means when it is able to travel in different parts of the body.
Yeah.
And unfortunately, that's the condition that a lot of people die from when they have cancer. Okay, that makes sense. So what's the staging about?
Staging. Okay, so to go back to the journey of the patient, is now we've performed a CT scan, we've performed specialist investigations such as endoscopy, the camera down the throat, and colonoscopy, which is a camera test from the back passage, to visualize, to sample the cells from the actual cancer itself. And then specialists sit together in a meeting to discuss the patient, the case, and what we found. And we call this the multiple disciplinary team meeting. So you have cancer specialists, you have medical specialists from that organ type, you have surgeons, you have the cancer nurses and the coordinators to make this all happen and to document all the important findings that we have. And what we say is, what is the TNM staging? So the tumor type, how far it spread locally, and has it spread anywhere else in the body? And depending on what the results are in that staging criteria, affects the management that we give.
Okay, that makes so. There's stage 1 and it can go up to stage 4 or above. And is stage 1 good or stage 4 good?
So what we say, the methodology of diagnosis of cancer and what the whole NHS is geared towards is basically early detection of cancer. Because if it's smaller when you find it, if it's not spread anywhere, there is more that you can do about it. And within the NHS, we've got something called a 2-week wait referral pathway. And this refers to any GP practice that a patient's registered at, and also at the front door of A&E, or even within the hospital when they're an inpatient and they've been treated for one problem, but there are concerns about cancer. And what this means, that because of this time-sensitive issue of trying to find cancer as early as possible to give the best chance of successful treatment, we say that if anybody has concerns or the symptoms concerning of cancer, that there has to be a referral within the first 2 weeks of that detection of symptoms to a specialist who can plan investigations to look for the cancer or provide reassurance that it's not cancer.
That makes a lot of sense. I think in that sense, the NHS is such a brilliant service where you might be going in for one thing to the hospital and you have signs of maybe cancer, and there's a referral process as fast as 2 weeks for you to get the ball rolling almost.
And what's beautiful is that, for example, we see in the NHS there are long waiting times in A&E, long waiting times for routine operations to take place. But every clinic has reservations for query cancer slots. So these are dedicated appointments for patients specifically who have query symptoms of cancer.
For the oncology department?
Within the general departments for the investigations of cancer.
Oh, interesting. I didn't know that. Okay.
Yeah, so from an oncology perspective, we don't, we're not really involved in the diagnosis of cancer, but once the diagnosis is made, we're involved in the pathway from then on in terms of the management and the treatment.
Interesting. So oncology just means cancer?
Yes.
Yeah, okay. So it's quite a needed field. Unfortunately, I know personally a lot of people who have suffered from cancer. I know a lot of people who passed away from cancer. I'm sure you have as well.
Yeah.
We know a lot of relatives of people who, when they hear the C word, it's all fear, alarm bells.
Yeah.
And being in such a profession is such a noble profession inside medicine to be in.
Thank you.
I would love to know, why did you choose it? I know apart from the obvious, but why did you go into this field?
So, to be completely honest, my decision to specialize in cancer work or oncology was quite a late decision in my career. When I finished medical school, I was quite undecided about what I wanted to do. I found pretty much everything interesting. And with the training pathway being very competitive and sort of difficult to get your foot into the profession, I had to spend time debilitating about really what I really wanted to do. Mm-hmm. And so I thought about GP for a little while. I thought about working in A&E, and I really liked medicine as I went through a lot of medical training, and I thought about geriatrics, elderly care medicine. But what really sort of sold the deal, you could say, was working with cancer patients as part of my medical training. I got an oncology rotation at the Guy's Cancer Center. Cancer patients are truly vulnerable because everybody's living a normal life, and then all of a sudden they receive the cancer diagnosis and all their priorities have changed. Yeah. Everybody has been living towards, working towards getting a good salary, having a family, working towards retirement, providing a good life for their children, and all of a sudden the cancer diagnosis has put that to a halt. Mm-hmm. And so you find that no matter what age group they're in, even whether they're male or female, everybody, but the cancer diagnosis becomes a sole focal point of their life. Yeah. And for me, working as a doctor, to be that person who either provides a cure for their cancer or provides a dignified way of passing away due to their diagnosis being untreatable, I find it a very honourable profession in that way, and also something worth me actually, working day and night towards this.
It's a beautiful profession. Actually, what happened, I'm currently looking after a cancer patient who unexpectedly had cancer. It's a very young gentleman, about in his 50s. He came in because some of his legs, the power in his legs weren't working as well. Yeah. They thought it might be something else, something vitamins or minerals or neuropathy that's causing it. Yeah. Did an MRI scan and he has grade 4 glioblastoma, which is, as we know, not the best type of cancer in terms of treatment. To the audience, what that basically means is brain cancer. And it's all the way from grade 4, so it's very severe brain cancer. And seeing this patient in his mid-50s, I spoke with him, and I speak very frankly with him. He's a lovely person, a lovely gentleman. And he said to me, Akil, before this, I had all these worries. Right now, the only worry I have is about this. Yeah. And he went to his oncologist. They gave him about 10 to 15 months prognosis. And he needs to start radiotherapy almost immediately. By the way, the service from the oncology department of getting that CT, MRI scan, moving through these different steps was absolutely phenomenal. Like, it was as fast as a click almost. And he then was put on a clinical trial drug. We'll discuss more about clinical trials, but the idea was just a few more months if he can get with his family, that means the world. And it's that mindset, and I'm sure you see it time and time again. Yeah, and that's another reason why I was really convinced to be within the field of oncology, working with clinicians, of them actually being my colleagues, and you could say my work family. And these are people who actually take everything into consideration to just try and look after the patients. When we look in the general hospitals, on the general medicine and surgery, they tend to be very busy because of the workload, and as a result don't really have the time to put in this level of focus and care for their patients, where social aspects actually mean a lot.
A very interesting case that I had come across in person myself was a patient who had a tumour in his neck. He was pretty young, he was in his 40s. And, the tumour itself was deemed incurable because it was actually invading one of the major arteries in his neck. And the risk to death was actually significant because if that artery bled, he would die within seconds, basically. And so he couldn't go home. And so he was in hospital and he said to us, as a team of doctors, that I would really like to marry my partner before I die. And so what we actually organized was a priest to come into the hospital. We put him and his partner into a side room, and all of us were actually witnesses to a wedding before he passed away a few days later. Whereas, whereas in the hospital in general medicine, they don't have the time or the ability to engage in this level of detail with their patients. But, for me, I find that even though his tumour or his cancer was incurable, we managed to bring honour and some level of satisfaction to his life before he passed away.
Fabulous. I think it's stuff like that just really, I know you have a lot of lows as a doctor, but when you see something like that, it just refreshes everything and makes everything worthwhile.
Definitely.
This is another thing about the NHS that I love, is because we hear a lot of negative press about the NHS. And one of the points of today's show is to make sure people understand how fantastic the NHS is. I know we saw it during COVID, but COVID isn't the only condition. As you see in cancer, you went above and beyond that role to make, and the team went above and beyond that role to make sure that this person you're treating is not just treating the condition, but you're treating it as holistically as possible. Yeah. And socially important is such an important thing. Yeah. Let's go back to cancer, Is cancer, let's take it even one more step back than that.
That's fine.
What are some of the red flags that we should note, that if we are noticing in ourselves or in our family, our loved ones, that could be indicative of cancer?
So what I would say in this is that this is a very broad subject, which does require a lot of detail, but I'll try my best to cover as quickly and as possible. And the symptoms of cancer really tend to depend where we think the cancer is actually originating from within the body. So, for example, if we're thinking about brain cancer, we're thinking about signs and symptoms of raised pressure in the head, as well as an acute change in personality with no unexplained cause. So, for example, I've known you from university, and I know how you are in terms of personality, relaxed, and hardworking at the same time. But then, for example, if I find that your personality has completely switched and you haven't been started on any medication which can cause personality changes, you haven't got any infections which can sometimes make you confused, and all your blood tests tend to be relatively normal, at that point I need to think, actually, do I need to scan your brain to see if there's any tumours inside? Because sometimes the pressure from the tumour itself can cause changes in personality.
Oh, interesting, yeah. For
example, lung cancers or cancers in the throat, we think about an acute change in voice and an unexplained cough which is persisting for months, you could say. For stomach cancers, or sort of lower gut cancers, you're thinking about alternating bowel habits with no explained cause, and also weight loss and anemia, as we were mentioning before. Yeah. For your blood type of cancers, you think about weight loss and night sweats. And also, by and large, the most indicative factor is also family history. Yeah. So if they're, for example, a brother or your sister or your mother, father, and for generations we can see cancer that's been running in the family, if you present with similar symptoms to what they have had, it makes us more concerned that actually you may have cancer yourself.
Okay, interesting. So we spoke about what can possibly cause cancer. So if you have a family history of cancer, you possibly have the gene, or in your DNA there's a defect of some sort that can make you more predominant to having cancer. Is that correct?
Yeah. So what I would probably say in terms of gene or DNA, to break it down, it's the coding which makes you you. So for example, to bring it in as another analogy, if you have a car, if it's made in a certain way, if it's made very strongly and efficiently, the ability for it to break down, the ability for its car parts to always stay functioning should always be high. But if the car is manufactured at a dodgy factory, then its ability for the car parts to break down is a lot higher. And so if you know where the car came from, then you know its risk of breaking down. And so likewise, if a family member or a family for generations have had have had incidences of cancer, then we know the risk is higher in that person.
Yeah. Again, I love your analogies, and I think the sign of a good doctor is being able to break down complex conditions into very simple terms so the patient understands. And
Thank you.
You clearly have that, Dr. Aikash.
Thank you.
So we spoke about the family history side of cancer.
Yeah.
What are some of the environmental factors that can cause cancer?
Yeah. So what we call cancer is something called multifactorial, which means that there are many different things that cause cancer, and it's never just one thing on its own. Yeah. And so the encouragement from here is for people to be as healthy as possible, because we find, for example, apart from just family history, we have smoking, which, you know, in our elderly generations, because the risks of smoking was not known at that point in time, many took up smoking and have found it hard to quit. And so smoking can cause many different types of cancers, but the most important one and significant one is lung cancer. Being overweight and severely overweight for a very long time increases risk of cancers, including breast cancer. And also then environmental, in terms of, you know, how healthy the person is, and, you know, for example, eating a lot of processed foods can also increase the risk of cancers. So it's, generally speaking, my message to the people watching would be just to be as healthy as you can. By and large, that should be some form of preventative factors for cancer. However, because it's all multifactorial, then it's never 100%.
Of course. So smoking, being overweight. I think people who also sit in the sun all day, that can increase your chances.
Sitting in the sun without any sort of sun protection cream or anything like that.
So everyone get your SPF 50s out, because that can possibly stop you from getting cancer. We spoke about the different types of cancer, but how does one, you know, go about in the NHS to make sure they can be screened for the cancers, for different types of cancer?
So different countries in the world have different screening programs. And so what's the most important thing is to think about is that just because we don't have one type of screening in this country doesn't mean we're deficient or lacking in our screening programs. What it is actually is according to the data in our country about what cancers are most in number and most common, then our screening programs are adjusted according to that. So for example, breast cancer is very common in the UK, but in Japan, it's stomach cancers because of different factors within the country, so on and so forth. So they have a gastric cancer or a stomach cancer screening program, but we have a breast cancer screening program. So the three main ones that we have under the NHS in the UK, and this, by the way, when we mention screening programs, is that these are screenings that happen automatically regardless of whether you have symptoms or not. The investigations for it are offered to patients.
Okay, interesting. So regardless of if you have any symptoms or signs, it doesn't matter. Everyone is given this service.
They're at least offered it. And it's up to the patient whether they want to join onto the program or not. So it's cervical cancer. So for women, it's for a cancer of a part of their reproductive organs. Breast cancer, as well as bowel cancer. And so for cervical cancer, it's offered from the age of 25. And it's up to the age of 64. So from the age of 25 to 49, the screening program, which is a cervical smear test, is offered every 3 years, and up until that, afterwards, after the age of 49, it's every 5 years. And the reason is that because if they can catch it really early, they don't need to perform any operations. There are smaller procedures that they can perform to actually eliminate sort of the cancerous cells, or pre-cancer cells is what they can see. So cells that aren't normal, aren't cancer, but has the ability to transform into cancer. And so it's offered at every GP practice. You have breast cancer screening programs from the age of 50 and up, and that can, they can see the GP for that and get plugged into the nearest hospital that has a breast cancer service in terms of ultrasounds and mammograms. You then have bowel cancer services for the more elderly gentlemen, and they offer a stool sample, which has quite high ability to detect small amounts of blood. I admit that not every sort of speck of blood within the stool is cancer, but in the elderly population, it's more concerning. And so if someone has blood in their stool, it's more important that cancer is ruled out first before thinking about everything else.
I think this is exactly why prevention is better than cure, and that's what
100%.
that's what the screening allows. Goodness me, we've spoken so much, and I haven't looked at my board once for any of the questions. We're just going, flowing, asking, having a conversation about cancer and talking about, so far we spoke about what is cancer, what are the different types of cancers, the screening process of cancer, how you can stop yourself from possibly getting cancer.
Yes.
We spoke so much in the first half. Unfortunately, we're just going to have to go for a very short break, but do come in because we have so many more questions to ask. And also, as always, if you have any questions and you want to call, this is a live show, so call on the number on the main screen, and we'll be happy to take any calls you have. Thank you. Hello everyone and welcome to the second half of Hello Doctor. I'm your host Dr. Akil Jaigida, and today we've been talking about cancer. We have our expert guest Dr. Aikach. The first half, we spoke so much about cancer, and honestly, a lot of these questions I couldn't even get through because you were just answering them naturally. And your explanations, I must say, is brilliant because the way you just go into such a complex condition and you've broken it down to such simple terms, it's praiseworthy.
Thank you.
Dr. Aikash, I want to know a bit more about you because part of this show is also about empowering the next generation, is making sure that the next generation can aspire to great heights, be it academically or sometimes maybe not academically, but as doctors, we want to make sure as many people get into this profession as possible.
Yeah.
Were you always hoping to be a doctor, or what's your story?
So I have to say this because obviously our community watching this is mostly Asian people, I would assume. Yeah. So a lot of the children and teenagers can sort of resonate with what I'm going to say. And you know, when you're growing up, you don't really have much choice in what you wish to apply for at university. Yeah. And while I would 100% encourage someone to go into the career of medicine if they want to, at the same time, I wouldn't necessarily force someone to go into it, especially, for example, me being the first doctor of my family, as well as coming from a working class background. You know, there are many challenges within the field that no one in my family could have prepared me for or even knew existed. And therefore, I went in and, you know, it was a rough journey in that way, so to speak. So I would say to anyone that wants to go into the field of medicine, get your work experience early, see what it's like on the grassroots level of what a doctor actually has to do, and see whether it is for you or not. If you make an informed decision, with the key word being informed, about whether this is for you or not, you're not wrong in making that decision either way. Yeah. However, I love medicine. I really enjoy it. It's why I'm still in the profession, 8 years on after graduating from medical school.
Has it been 8 years?
8 years, yeah.
Oh, goodness me.
It's time flies.
So myself and Dr. Aikash, we actually went to the same medical school. He was my senior. I know him very well in that capacity. But I remember the day you graduated. It's been 8 years.
It's been 8 years, yeah.
Goodness.
So yeah, but for me, what I would say, working in healthcare and working as a doctor, the way I see it very different from every other job that I could be applying for, is that for me to be a good clinician, for me to be a good doctor, I have to be a good human being at the same time. And not many jobs actually require sort of the marriage of these two aspects of being very good clinically, knowledge-wise, hand-eye coordination and dexterity, but then coming across with honesty, sincerity, hard working, you know, making sure that I'm doing the most for my patients every single day and then going home, you know, satisfied with that. You know, not many careers allow me to be both at the same time, as well as going home knowing that I actually made a positive difference to my community.
Definitely. Again, so you mentioned some of the challenges of being a doctor.
Yeah.
I know everyone has their own challenges. I have mine, you have yours. I want to hear yours. What are some of the challenges you went through?
So, I mean, the obvious ones being, you know, the amount of studying that needs to take place, difficulty regarding that, the night shifts, the weekends, you know, there have been a lot of weddings that I've missed, for example, because there were shifts that I couldn't swap with colleagues and so on and so forth. It's been a bit tricky sometimes, even, you know, getting Eid day off because of cover in the hospital. But the ones that you could say I was not prepared for was the specializing sort of pathway, because there aren't infinite numbers of training positions to get into every single specialty. That is very limited. And as a result of competition, you could say, then you know, you have to think about the ability to travel for your job. So luckily, I've been very lucky, been very fortunate to say that the furthest I've ever traveled for a job has been Kent. You know, but I know, for example, people that I've graduated with from medical school, that, you know, they graduated, they got the medical degree, but for the first 2 years, they were in Cornwall, for example, because that's just where they were stationed. And, you know, if you want to think about something such as neurosurgery, which is operating on the brain, or cardiothoracics, you know, the heart and the lungs, there are very few centers in this country that actually train people for this. And so you have to be willing to travel to get those skill sets. And so this is just something for people to think about, that it's not just you graduate, you go to medical school and you work at your local hospital, or you just work at your local GP, that everybody gets funneled into a national sort of competition application program. And then from there, the sieve happens, and then they decide, you know, who scored the best, and who's worthy of their training program. And then after that, it's, you know, who gets priority in choosing where they want to be.
And I think if you even have a partner who's a doctor, you could be working in 2 different places altogether.
Exactly. Yeah. So in that way, a lot of sacrifices have to be made. And it's just about whether someone is willing to do all of that, or whether, you know, someone has other priorities in life. And either choice is not right or wrong. It's just about what the person thinks is best for them.
I heard this very funny story. It's a true story because the person who was experiencing it told me. So he's a doctor, his wife's a doctor. He was on day shifts, she was on night shifts. The next week he was on night shifts and she was on day shifts. They lived under the same roof, but they didn't see each other for 2 weeks.
It happens.
I thought this is crazy.
Yeah, it happens. But you know, every profession needs people that are dedicated to it. Because if someone in our community has a problem, then there needs to be someone to take care of it. So, for example, if everybody was doctors, but your car broke down, there wouldn't be a mechanic.
Yeah, true.
And if everybody was a mechanic and you started having a lot of chest pain, you were having a heart attack, there would be no doctors to take care of it.
Yeah.
So the most important thing, I'll probably say, when choosing your career pathway is about what are you taking care of for your own community? What is there a shortage of? And where do you feel that you can make the most impact with the skills that you have?
I love that word, impact. So instead of driving for, let's say, materialistic success, you're driving for impact. And when you drive for impact, the success just follows.
Yeah, that's what I would say,
Because you're prepared to put the hard work in.
Exactly.
I'm sure your job is never easy, emotionally and physically. The hours you do, sometimes you're starting earlier, finishing a lot later. And those are sometimes unpaid hours. Because we just do it for the you know, the goodness of the patient. Emotionally, I can imagine that some of the patients that you see, you're breaking bad news again and again and again. To the point, do you sometimes get scared that you're becoming almost distant from your emotions in that respect, or?
I mean, the problem is that when you work within cancer yourself as a field and a profession, the emotional distancing that you have from the sort of profession or from your day-to-day work, one, takes place, and two, every little pain that I get, you're like, oh, is it cancer now? Because obviously I see it so often. But I would say there is a bit of emotional distancing, but but what I would rather say is that it's mostly an emotional reservation for scenarios that actually deserve it. Whereas, you know, when you first go through your training, everything is new, and so everything requires a lot of devotion, even from your emotions. But then as you get more experience and you know about what's in your comfort zone, what you're able to quickly deal with, what's a more complicated situation, and then those truly heartbreaking scenarios, then you kind of gear yourself accordingly to be able to cope with those circumstances.
I think breaking bad news is a skill, and it's something that you get prepared for it from med school. And I remember once, I think I was in F1 or F2 at the time. I think it was F1, my respiratory rotation, and the doctor, the consultant who went and broke bad news that the patient, who was a mother to 2 kids, had cancer. Yes, it's the worst news that she could possibly hear, but I promise you, I think she heard it from the best person, because the way he broke it down, and he gave her time, and he explained the condition, what the next steps, and I think time was the most important thing. Just saying what the bad news is and giving her time to absorb it. And
that's why you hear it sort of in conversations sometimes between doctors, is medicine a science or is it an art? And I'm more inclined towards it being an art, because all my years of training within medicine, what I find is that my decision making is not necessarily based on protocols, but it's based on my gut feeling. You know, there's someone that, you know, the blood tests are normal, everything looks fine, but when you look at the patient from the end of the patient, just something's not right. And then based upon that, you make a decision, and then you find out that what you were concerned about was actually true. And I think at the same time, with a lot of, aspects of medicine, and being a doctor requires, skill sets from every part of your character. It's an art form, because you can get 2 people performing medicine in the same way, but then the satisfaction from the patient is completely different. And it's just about the way information has been conveyed and delivered to them. And that's ultimately what changes patient care and satisfaction.
Yeah, exactly. I think it is an art. You're in the field of oncology, so you're in the field of cancer. If you weren't in the field of cancer, what other field would you have gone into?
So I would probably say elderly care medicine.
Okay.
Yeah, and it sounds very different from the field of oncology, But something that I've realized within sort of my training as a doctor, one thing I do enjoy is looking after vulnerable people.
Yeah.
I admit that that is a very subjective answer, and everybody has their own personal answer to that sort of stance. But for me, I find elderly people, especially in this country, very vulnerable because they're in a physical and sometimes mental state because of dementia, of being incapable of actually looking after themselves, incapable of actually conveying what their problems are, and the impact it has on them and their families at the same time. Being a doctor, sort of sitting within that field and taking care of all of this is something that I did enjoy, and I have a lot of experience in elderly care medicine, but specifically oncology managed to trump that just from the experience I had while training in those jobs, and that's the reason why I'm in cancer work now.
Definitely. I think elderly care is also, elderly patients are some of the most cutest patients, I'll be honest. When you see the old grandma who's sitting there, and I've seen it time and time again, just this week alone, honestly swells up my heart because they are so, like, they're so cute and they're so honest and straightforward. But you mentioned something that we sometimes, dismiss, which is a lot of elderly people do go through depression. They go through mental health issues, but we don't realize it. We don't actually take it as an active part of what's going on with them, as we do with maybe the younger patients.
And I think as well, at the same time, when we look at the lifestones that we achieve at this part of our age, we all have friends that are going through the same thing. For example, our close friends and our close family members, siblings and cousins, they're growing up, they're getting grades, whatever they may be at college, they're going to university, they're getting a job, they're getting married, they're having children. Whereas when you get to that sort of age, majority of people that you've known for far longer and have gone through all these milestones with them are now passing away. And that in itself can have a negative impact on that person, because sometimes they think that they're just waiting their turn. And so, managing the health problems within that sort of scope, I find it very rewarding.
There was a study, and I can't remember the actual title of the study, but the point was they looked at depression within the elderly population, and they saw those who are given a form of work almost, and those who are not. And they found that depression was higher in those who did not have work. Now, I'm not saying go stick your elderly mother or your grandma to work, or and force them, do forced labor or anything like that. But I'm saying if you give them activities and you give them a purpose, studies have shown that depression rates decrease.
And I think as well it's because of isolation. Especially, in our communities, what's great is that sometimes you have multiple generations either in the same house or very close by to one another. And, that's why, a lot of children have very close bonds with their grandparents, sometimes often more than their parents, because their parent has been a disciplinary person in their life, but their grandparent has been that nurturing, kind person that often, takes their sides in the little family bouts. So that, and I would say these kind of relationships really is a good preventative factor for mental health issues.
So would you recommend oncology to other doctors?
Yeah, but what I would probably say is, as I was mentioning before, we need people being able to make an impact in different fields. And that's true also within the field of medicine itself. Everybody can't be an oncologist, because when I refer someone for an operation for their tumor, I need a surgeon. And so I think it just takes a little bit of sit down and reflection for a medic or a surgeon at that time, or a doctor, I should say, to think about what it is that they actually want from the field, what they're able to provide and what they're willing to provide. And then based upon that, make a choice about what they like. Because when I was in my first year of doctor, so I was an F1, a foundation year 1 doctor, I was working within this field of psychiatry for a good 4 months. And my consultant, he asked me what I wanted to do, and I said, I'm not really sure, just getting a feel of everything at the moment. And he said to me, you know what, Bilal, choosing a specialty is like marriage. It's not the good things you like, but it's also the bad things that you can live with. And I think, generally speaking, that's a very important factor when to take into consideration, because I can love, for example, neurosurgery. But am I willing to go through the very difficult competition ratio and as well the nights and so on and so forth that are required from it? Some people would say yes, some people would say no. And so it's about really what you're able to actually give to the profession itself. That is a major influencing factor in decisions about career.
I think, do you remember in medical school when we were learning about a condition and we thought we possibly had that condition? I think it's called medical student syndrome. Right? Do you have that now being a cancer doctor? Do you think?
I mean, to be honest, it's made me want to have a good relationship with my GP. Reason being is because actually if I'm getting sort of repeated blood tests done sort of every 6 months to a year, they actually see my face, for example. It makes it a lot easier for me to say, I've got this problem, what do you think is going on? Whereas, you know, someone who's not being able to have contact with a GP to keep on top of their health, you know, it becomes a lot harder to plug them into the system sometimes.
Yeah.
So, you know, what I would really, you know, encourage is, you know, if you're the age of 40 and above, you know, start thinking about your blood pressure, start thinking about cholesterol, and just engaging with your GP as a whole, so that whenever you do have symptoms that you're worried about, you're kind of already in the system with the GP to actually follow this up properly.
Definitely. I think GP basically was a family doctor. It was the family doctor who would come in and they would know pretty much all the family dynamics. They'll know about you, your health. And so when they said, and you touched on this, which is such an important point, you mentioned gut feeling, but it was more experience, I would say when a patient comes in, everything's normal, but something just does not look right. And that's what a GP can do essentially as well, because they've seen this patient again and again, and then the experience of knowing that person, they could say, yes, the blood tests and blood pressure and all the other obs are all normal, but something doesn't look right. So I think that's, you know, beautiful advice. Get engaged with your GP because that service is available.
Exactly.
It is hard to get an appointment, granted.
I mean, and also me being a doctor doesn't give me any greater rights to get access to the GP. I still have to wait, you know, however long it takes to get an appointment. But you know, perseverance is important.
Definitely. I did my GP rotation, so I know how busy they are. But once I had to call the GP, and I was on the call, and I was like, "What's taking them so long?" you
forget yourself.
Yeah, as a doctor, you forget yourself. Let's go back to talking about you yourself. You mentioned that you would recommend this field to others, but given, you know, the circumstances, of course. But what was one of the most interesting cases you faced in the field?
Okay, so the reason why I find oncology interesting, as well as, you know, obviously the human aspects of it, is that you really have to be on your toes in your skill set, because a lot can go wrong, because you're managing the cancer. Sometimes when they come into hospital, they're either having a complication of their cancer itself or the treatment that you've given, as well as their normal existing medical problems. So you really have to be on your toes. And so I was working as an oncology senior house officer, so SHO in abbreviating it. And we had one patient overnight that had lung cancer, but then started to have chest tightness. And so we scanned this patient overnight because, you know, the blood pressure was dropping, the heart rate was going up. And actually what we found was a tumor from their lung was spreading into the lining of their heart and was creating fluid. And this fluid that was also mixed in with blood was filling up so much that it was actually compressing the heart and actually caused it to stop. And so this was what we call a cardiac arrest situation. And then so we had to obviously perform the emergency protocol of chest compressions and the other parts of the algorithm. But then as well, we had to get the cardiothoracic surgeons, so the surgeons for the heart, to put in an emergency drain into the heart to actually drain it. And we were able to restore a heartbeat afterwards.
That is a pretty interesting case. Is the patient okay afterwards? Or?
Yeah, they were okay. But what they have is a permanent sort of slit in the lining, so that doesn't happen again.
You know how modern medicine has changed is phenomenal. Like, you can't keep up with the guidelines because things are coming in and it's changing up the entire game of medicine.
Definitely.
You know, Ibn Sina, who was the father of modern medicine, what he broke down and to what it is now.
Exactly.
Is incredible, and it keeps on changing because of technology.
Yeah, and you know, in that light, you know, we don't necessarily experience it from day to day in terms of our work, but medicine is a heritage from the people that have lived and worked before us, and we've inherited their knowledge, we're practicing it, and then we're giving it to, you know, future medical students and training doctors as well. So I see myself as a link in that chain within the field of oncology now.
Another beautiful analogy. Quickly going back onto cancer, because our time is a bit short. Is cancer contagious?
No. Yeah, but what I would say is that for patients receiving chemotherapy or treatments that are, you know, affecting their immune system in order to treat their cancer, is to not necessarily be in contact with someone that's unwell at the time. Because your immune system is suppressed, you're at risk of not only catching infections, whether it be viral or bacterial or fungal, but because you don't have the immune system at that point in time to fight it, the reaction to this infection can be a lot more severe and life-threatening. So what could be mild in myself and yourself may actually be sort of life-threatening to a cancer patient that's on treatment.
Okay. And just quickly touching on the different treatments for cancer.
Fine. So bringing it back to the first part of our conversation before the break about the pathway of a patient. So we've got the staging, 1, 2, 3, 4, has it spread anywhere else? And then this really determines what happens to the patient.
Yeah.
And so we say that the single most curative outcome for a patient is surgery. But for a patient to be a candidate for that, to be eligible for this kind of treatment, the tumor has to be very small and contained and not necessarily spread any parts of the body. Yeah. Because if I've got stomach cancer and it's spread to my lung and it's spread to my brain, if I take out the stomach cancer via surgery, I've still got cancer remaining. Yeah. And that will still spread everywhere else. So if it's very localized and very contained to a small area, then that can be taken out surgically. Yeah. What happens then is, the surgery takes out the cancer that you can see with your naked eye, but it doesn't necessarily deal with what is microscopic and very sort of small on the molecular level. And so that's why you have chemotherapy. And so chemotherapy is treatment that kills cancer cells. Unfortunately, sometimes kills your natural human cells as well as a side effect, but it gets rid of what is not visible to the eye that could be cancer anywhere else in the body.
So it's a chemical?
So it's a chemical.
Yeah.
Some cancer treatments are in the form of tablets. Some of them are in the form of injections or infusions. You could say it runs over a few hours in a day.
Okay. Yeah. And then so you got surgery, chemotherapy, I think there's radiotherapy.
So there's radiotherapy, which is what I'm hoping to also specialize in.
Yeah.
So essentially it's high dose X-ray beams. So we say radiotherapy, it sounds fancy. You're not going to glow green and turn into the Hulk or anything like that. Yeah. But for example, if you've ever been unwell and you had a chest X-ray, you get radiation X-ray beams that fire through the lungs to light up an image, for example. Yeah. What radiotherapy is an extremely high dose of a version of this, basically. And what it's known to do, actually, is essentially when it's fired directly at the tumour, it breaks down the tumour cells.
Oh, interesting.
Yeah. So there are many functions of radiotherapy. Radiotherapy in and of itself can be curative of certain types of cancer, such as prostate cancer, depending on the staging again. Or sometimes we can use it in what we call the palliative, whereas, for example, the cancer is not curable, but we want to relieve them of symptoms. So, for example, we have a lot of cancers that spread to the back and causing compression of the nerves, and they can't move their legs as much. And so they have a lot of back pain because of the tumour being in the bones and touching upon the nerves. And what the radiotherapy can do, if it's fired at the back, can shrink the tumour cells and decrease that compression on the nerves, therefore providing some recovery to mobility and also decrease in pain.
Fantastic note to end with. I think you summed up cancer so well for us. There's so many questions I still wanted to ask you. Unfortunately, this is all the time we had today.
No, that's fine. It's been a pleasure to be on here.
Thank you. Inshallah, we can bring you back on.
Inshallah.
And we can finish the rest of the questions, because I'm sure myself, definitely, I've thoroughly enjoyed speaking to you and to the audience. Thank you today for joining in. Sorry, this is all the time we have today. Thank you, Dr. Aikash, for coming in, and I'll see you in another episode of Hello, Doctor.